Hey everybody, welcome back. It's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. We've had quite a day here between Dr. Hill trying to get here late. He's behind the scenes somewhere, so he's going to be occupying that chair over there. I got Ray Pace with me again, and our guest, Dr. Rob Flannery from Drzezinski. I've been practicing this because last time I was all over the place, but Drzezinski Sports Medicine Institute. And hey, thanks for coming back.
Thanks for having me.
And really, we're going to encourage all of you, hey, jump in there. Any questions you have about sports medicine, we're going to talk a little bit here about the heat injury stuff again, because yet again, that's kind of cropped its head up in this week for you. But anything you have regarding sports medicine, sports injuries, or the heat illness stuff, send those in, drop those into comments. I think today we are only on Facebook, so your friend that is on YouTube might have to get this tomorrow. So tell them to pop in over here and watch us on Facebook, and then we'll get this posted a little bit later today on the YouTube, so everybody can join in. So. Let's talk a little bit about that case that we were talking about off air. You said that, even though we have gone through this incredibly laborious I think it's been 2 years now, of trying to get the message out about a proper treatment of heat illness and how important it is to cool these people. Anybody with heat injury, not just athletes. Obviously, that's your focus,
right.
But anybody really, we're still have this. I mean, as of this week, there's been mindset of just load and go. The hospital can take care of it. So
right, yeah, and it's no longer in the fine print, right? If you go into the protocols and,
right.
you read the protocols, and I think everybody in Northeast Ohio is using the same heat protocol. That
correct.
If there is a cold tub available, use that, cool them until their core temperature gets below 102. Or until their mental status changes if you don't have that core temperature. We really want them to be cooled on site. We had an issue at the marathon this year where we had someone, and this kind of hits on the core temperature, and I know it's not the easiest thing to get around, but you really do need the core temperature, where they took an oral temperature on a guy and it was normal. He
right.
had some altered mental status, and so you start thinking about what the different things are. It was hot at the marathon, and it was towards the end at the tent. They put him in the tub because, anything you need to do for him, let's say he's, hyponatremic, you can put an IV in, you can do that in the tub. While they were getting him into the tub, they took a rectal thermometer and got a core temperature, and it was 108 plus.
That's nuts.
So it was a 10-degree difference between the oral thermometer. So for whatever reason it read, whether it was just, who knows what it was,
right, yeah.
But the 10-degree difference. And so if you don't put that guy in the tub, or you don't get that rectal temperature, and you just send him off, by the time he gets to the hospital, who knows what his temperature is or how long it takes. And so, and the hospital may not have, the hospital may not have the ability to cool the person as effectively as you do there with that cold tub.
It's not even a may not. They don't. They straight up don't. Even if you give them a ridiculous heads up, they're going to have to ad hoc things together to get these patients, keep them cool, right? They're in that protocol. We even went so far as to put a statement in. I'm paraphrasing, of course, but it's worth the time to even ad hoc something on scene if you can, right? So, let's say your engine's on scene, you take a salvage tarp and put the patient in a salvage tarp, dump, start a hose on them, send somebody across the street to Quickie Mart to get a couple bags of ice, dump them on. It's worth that time. You shared some stats which in the recorded version in the previous 3 weeks about their recovery if they're treated aggressively, and why this is so important. And this is, of all of the stats and all of the things that we do, right? We see minuscule returns on a lot of our work sometimes, but this is something that's completely completely different.
Completely treatable.
Yeah.
100% treatable. So recovery 100% of the time, as long as they're cooled within the first 30 minutes. And that's why you can take the time on site. I know nobody wants to be on site longer than what they
Nobody
have to
wants
be,
to, right.
but it is 100% treatable if it's treated on site correctly, and those things are available. And so that's getting together with your athletic trainer or your race director or whoever it might be to make sure that your emergency action plan for heat illness is in place and proper and up to speed.
Right. And simple tools here. We're not even talking about complex or expensive tools, right? And this is stuff we have access to, right?
And it doesn't even have to be your own, like in my setting. Like, I know we talked a lot off air even before we started when we were working out the technical difficulties, but my organization is able to use, the school's resource or whatever field you're on. What do they have in their field house? What do they have? What are the capabilities of the facility? So if we want to cool that patient in the first 30 minutes, you can maybe have to move that patient a couple hundred yards, and then now I'm into a building with the resources that I need, with a commercial ice machine, with an ice bath, water, and I can bring the rest of my equipment into that building that I need. Right? There's no, I think you hit the nail on the head there. There's no magic wand at the hospital. A lot of times I think we're like, oh, we're going to get them there, and the doctors are going to do all this fancy stuff, and it's like, there is no ice bath in the decon room, right? That's just where we give people a shower, and we know that's not effective enough. So, they're going to have to really even over-adapt farther, in my opinion, than we would in fire and EMS, or working with your athletic trainer and whatever, maybe the facility has the capabilities, which is kind of what we lean on in our organization, but it works. It's right next to the field. It's easily accessible. We have a plan, and we're going to be there a while because, there's always those cases where people want to rapidly transport, and then, what is the outcome of that patient? Did it cause cardiac arrest? What's the survivability of that patient now? So we talk about rising temperature, but what's the longevity of that patient, essentially? What's going to be their outcome?
Right, and that's what the Corey Stringer Institute has looked at. Their numbers are over 3,000 cases that they looked at that we talked about on the recording, and anyone that was cooled to under 102-degree temperature within the first 30 minutes had 100% recovery. Either they had no disability at all, or short-term disability that resolved in a couple of weeks, and they were no worse for the wear moving forward. And it's simple things to have. It's ice and water and something to stir the pot.
Stir the pot, right?
Yeah.
There was, I was engaged in a conversation probably 2-3 months ago. I should have brought this up on the recording. I don't know why I didn't, but it was like 2-3 months ago. And they're like, well, if we get them to the hospital, they have cold saline there, right? Like, this is going to magically fix it. And, my rebuttal to that was, hey, look what's not in your protocol anymore. Because we had, for the longest time, for post cardiac arrest cooling, right? We had both, peripheral cold packs as well as cold saline if your department could support it. I remember, my department, every morning we were signing out a bin with a cold pack and cold saline for, that post-arrest case. Guess what? You don't have enough, and you can't cool them fast enough. It's the best way. There's no magic wand at the hospital. Cold saline, might be helpful if you're already cooling them, but not to, it's not going to bring them down from 108. 2 or 3 liters is not going to. And then the flip side is it's not in protocol now because A, it didn't cool fast enough or work, and B, there was far too much pulmonary edema, right? When you would bang them with a bunch of post-arrest specifically, but it would be a similar situation in a hyperthermia situation. You're going to drown them in a bunch of cold saline and create more problems than. Again, it's easily fixable with simple things, right?
Right, and the cold saline is the duck's feet thing, right? So if you put a duck in cold water, it can still swim.
Right.
Why don't they get hyperthermia in their webs or internally? And it's because the arteries and veins are so close together that the warm blood coming from the body down to the feet is so close to the cold blood coming back in the veins that there's an exchange of heat. Same thing happens there. It's the exchange of cold as you put it in that peripheral IV. By the time it gets into the core of the body, it's about body temperature. By the time it gets there, it's not doing too much to cool them down. It will cool them down, but not that half a degree a minute that we need in order to get them down within that 30-minute time frame.
And then, yeah, even the combination of things, because that was originally it was like, oh, well, just putting, cold packs in the axle and stuff. Well, that's not cutting the mustard, so the combination therapy would be enough. And it still wasn't enough, right? There's nothing that beats just full-on submersion and
use the largest organ in the body.
Right, exactly, yeah.
Exchange that across there.
Yeah.
Right.
So, but... Then I think the other ad hoc kind of way we were working around is if you had a body bag, right? And I think it's a little morbid, but you can stick them in there, make a slurry, fill it up with with water and ice if you had to, right?
And keep it moving.
And keep it moving, right? You could just jostle that around, but.
Mm-hmm. Well, even some of the smaller items we have, just to go to not to go to the fire side, but specifically in our organization in our county, the EMA got a grant, and we have these maybe like 6 feet round containment pools for like if a saddle tank on on like a semi
like
is leaking, we can easily deploy it, put it underneath it. Hey, at least I'm containing my leak while I actually have time to plug it. I could also not use the same one, obviously, but I could use a different one, a clean one.
Diesel.
Yeah, why does it smell like diesel fuel? There's a sheen on the water and the ice. But no, same concept. Even if you had to purchase them, they're not that expensive. Right. They fold up, fit in a compartment. So there's another option. This is so easy to do, and in my opinion, seems to be common sense. And what we've worked with Dr. Flannery on through, the sports medicine classes that we do, Con Ed classes that we do, it's very easy to adapt and do it. I don't understand.
Yeah, no, it's how little pre-planning on our behalf, right? Yes. And when these events are happening.
Yeah.
It's not like somebody's like, oh, by the way, we're going to do a thing today. No, it's usually well advertised, and it's generally known, right?
Or it's practice, and the athletic trainers, and I think that speaks to why athletic trainers are so important to be at high schools, so that they can do the pre-planning, so that when the EMS does show up, that kid's already in the tub and getting the treatment that they need, and so those athletic trainers, not just for helping with injuries and things like that, but it really it's that pre-planning of practices and walkthroughs and game day situations, and making sure that all those things are available.
And we spoke in the recorded versions about in an ideal world, right?
Yeah.
That AT has a continuous rectal thermometer, continuously monitoring rectal thermometer. But if they don't, the protocol was very intentionally scripted to allow us as EMS providers just to follow mental status, right?
Yeah.
So dunk them until they come back, and we put a time limit. Like if they're in for 20 minutes and they don't come, something else might be going. There's something else going on. It's 20 minutes.
There was essentially another item there to kind of but trigger you to change your response, your treatment.
Something else might be up if they're if you've chilled them this long and something hasn't happened, but. Yeah, and you're absolutely right. That's been fairly standard here in the in the entirety of the region, right? Doesn't matter who your medical direction is, who your medical control is. The Cleveland Clinic, Metro, Southwest General, UH. We've all gotten together, and there's a core protocol for all of that stuff with very little variance, and one of the things that's standard across is, of course, is this heat, right? So everybody should be speaking the same language, and it's a little bonkers. We're at this point really kind of still having this discussion, but still needs to be had, and we all need to spend time on what's the backup plan and how can we ad hoc stuff if we're not in a sports setting where everything's laid out perfect for us, right? But now you started to talk a little bit about the athletic trainer and that pre-planning. Let's hit that again, because honestly, having all these tools and all this goes out the window if everybody's not talking right out of the gate, right, or not speaking the same language. Hi, buddy.
Hey, how's it going?
Thanks for joining us.
Yeah, welcome.
Yeah, no, I mean, I think it starts with your standard operating procedures, right? And I think that's probably one area where when we start talking about emergency action plans, the lines get blurred a little bit. What is an emergency action plan, and why aren't we using our standard operating procedures more? because the emergency action plan, in my opinion, should be very precise, very short, and really only the steps that you need to address that emergency.
Right.
Anything beyond that, when you start talking about post-event breakdown and what went right and what went wrong, that needs to be in your standard operating procedure. When you start talking about calling administration for the school and letting them know what's going on, that's not part of the emergency. That's slowing things down. So if that's in your emergency action plan, it needs to be in your standard operating procedure. Yes, they absolutely 100% need to know,
right? Yeah.
But they don't need to know in real time unless they are part of that emergency action
unless
plan.
they're doing a thing to mitigate the right.
Exactly. And so it starts with reviewing your emergency action plan and making sure that it is venue specific, that it addresses a specific issue. And so you need to have an emergency action plan for a conscious athlete, for an unconscious athlete, for a heat stroke, for diabetes, for hypoglycemia, for seizure, for mental health. You need to have these emergency action plans for each venue on campus. And I know it's redundant, and I know it's difficult to practice all of them, but that's really what you need to have at the start of the season, start of the year, before you can move forward with anything else, to make sure that these athletes are safe.
Absolutely. And then from our side, right, we need to make sure that we're interfacing with those athletic trainers or command staff of the school or the wherever the event's being hosted, right?
Right.
Have all that stuff ironed out ahead of time.
100%.
That should not be taking place
At the emergency.
at the emergency,
No.
right? That's when it's all going to come apart, right?
I'm a planning guy. You know that. I love
Was
to-
there
I
any
love to plan.
planning of recent in a big event that's happening right this second that maybe you got here late?
No planning there.
No planning
No,
whatsoever?
those are just regular old patients having regular old emergencies
But,
at a fair.
But yeah, I know even leading up to that fair, there was a bunch of pre-planning and meetings and whatnot on who was going to do what and who was staffing it, and there's a whole complement of people there.
There are, and so I was at the Canfield Fair earlier today and dealing with some patients there, and we have safety meetings every morning. We talk about the day, we talk about issues from yesterday, and like how we're going to be better today, what the plan is going forward, what the weather's going to be like, how we're going to treat heat emergencies. At fairs, we deal with a lot of bee stings, so a lot of bee stings today. I was waiting because I had a patient that had a history of anaphylaxis. They got stung by a bee, and I'm not going to leave him there. I'd rather take care of him, make sure he's okay.
We would rather you take care of him as well, right?
We'll start the podcast a half hour late.
But nothing yet.
No.
All right. But yeah, that extends. We've spoken about. I know you said ballet, and we've talked, of course, a lot about football on the recorded. Baseball, but even extends to stuff like this. Fairs and community gatherings and stuff like that.
Any event you have a large amount of people at, right?
That's that same mindset and protocol should be applied, right?
Absolutely.
Yeah, all event.
And I think one of the things that's really stuck with me when I listened to this podcast was the AED in 3. And even thinking about myself, like, do I just buy an AED for myself and put it in the back of my car and just carry it to all my events that I go to? Because, I mean, you probably don't. Do you guys have tourniquets in your car?
Yeah.
Yes.
Do you got 14 gauge needles in your car?
Yes.
Yes.
Do you have a 60 ET tube just in case?
No.
Yes.
Do you have an 11 blade in your car?
Maybe.
I guess the question.
But it's in my bomb kit, so I mean that's a unique situation. Does every paramedic know?
No, but I mean, we still have tourniquets. I still have a Israeli bandage in my car. I've got stuff for trauma patients. Why don't I have things for a cardiac patient?
Arrest.
Yeah.
Why not just have an AED in my car? Since I'm a doctor and I'm going to kids' soccer games or football games or ballet or gym or dance or whatever, and not necessarily for the kid that goes down, but the adult that's attending the recital.
So you have to work an extra 7 minutes to pay for it. I mean, you'd be all right.
Taxes would say.
Taxes, okay. 8.5, 9, all right.
But that's, I mean, I think you've seen that bore out in the research, right? Is you look at national average, if you have an AED that's has to be used on you, your chance of survival is 4, 5, 6%, somewhere in there. It's pretty low, national average. Then you start looking at some of the communities and cities that have implemented putting AEDs in all of their municipal vehicles. So garbage trucks, street sweepers, police vehicles, anything that is a municipal vehicle has an AED in it, and they're going up to 30, 40%. And then you look at, where's the best place to have a heart attack or cardiac arrest is in an airport, because there's so many people there,
AEDs,
or a casino where they have eye in the sky, everything is
Everybody's
monitored,
watching,
and they have a team, just like at the airports, where they have a team that is specifically ready to respond to sudden cardiac arrest. So the more AEDs that are out there, the greater the likelihood of surviving after having that event.
So,
I mean, Kent just had a arrest. The lady that they saved, she was a employee at a university, and they originally showed up, AED, got her back, and came to the firehouse.
I saw
just
the picture.
other day.
It's very nice on Facebook.
Yeah, exactly. So, I mean, the easy access and quick access. We talked about this with the resuscitation one, too. It's early high-quality CPR and early defib, right? We all know that, right? And then we went down our discussion about medications, but I guess that's something that I can easily carry with me and know how to use. And honestly, there's a lot of people that have gone through AED CPR training that knows how to use it, and it's really easy. You turn it on, it tells you what to do.
Tells you what to do, right?
Well, now even if you think about it, high school students in Ohio are required to be exposed to CPR, how to do adult CPR and how to use an AED. So now that's required for them to graduate if I could talk. And one of the simple things we always do is we always pick a student, and then we always pick a teacher, and we make one of them go get an AED.
Oh, nice.
Right? Because they're like, yeah, we have one in the school. And then where's it at? Right? It's just like, it goes back to, if we're on the soccer field, did the athletic trainer bring it? If I can look up and know that if Dr. Flannery's the athletic trainer, I know that's where the AED is. Is there an AED here or not here, right? So we have to be able to locate it, get it there, and put it on a patient. And a lot of the stuff we look out of, like Seattle, Washington, you want to talk about out-of-hospital survivability rates, it's because early notification, and then that emergency medical dispatcher saying, you're the one calling 911. If you don't know how to do CPR, then I'm going to teach you how to do 911. So we get hands on the chest right away, and then other people can help prior to that. And then with apps such as like Pulse Point, that can tell you where the closest AED is. So I believe it's the city of Kent that took that initiative downtown, where they're loading all the locations of the AEDs in the downtown area onto the app. So even if you're not familiar and you're just like, hey, I want to eat tacos in Kent today, and I'm in this restaurant and this happens, and you're helping somebody, you could pull that app up, and then it'll say, hey, there's an AED, 2 storefronts down that's accessible to a community member. And it's really, really important. Same thing in sports. It has to be easily and readily accessible. So I agree with you. I think about that a lot too. We carry all that stuff for trauma. That's a great point.
I think he is setting you up very nicely for an initiative that you guys have started at Brzezinski. So tell us a little bit about the AED in 3.
Sure. The AED in 3 challenge, we launched it maybe 6 weeks ago now, and basically having all of our athletic venues, and it doesn't have to be UH, it can be any high school athletic trainer, go to that facility, figure out where the closest AED is, take 3 people that are of varying athletic abilities, 1 slow, 1 fast, 1 medium, so Goldilocks and the 3 bears, right? And have them run from the furthest spot at that athletic venue to the AED and back, open it up, turn it on. Yeah. That does a couple of things. One, it tests your emergency action plan for that venue for cardiac arrest, that you can get to the AED and back in less than 3 minutes. It tests your machine to make sure that it opens, turns on, and has pads that are not expired. And then it also, kind of shows what you need if you can't get it within 3 minutes. And so what we're finding, we did that, we started about 6 weeks ago. We've had close to 24 schools now turn in their videos. We want them to videotape it, and that way we can look at it and verify that it is less than 3 minutes, and they've practiced their emergency action plan, and that's great. That's the main part of what we're doing, but also they can prove a need for an AED. And so what we're finding is The venues that are indoors are all almost 100% covered, and we hear from the schools and we hear from the politicians that, every school has an AED. Absolutely, I 100% believe that every school has an AED. The problem is that not every athletic venue is within 3 minutes of that AED, and so we're seeing that our outdoor venues we're having times of 5 to 9
Poorly
minutes,
covered,
and so it's not covered as well. And these a lot of times are facilities that the community uses also, and so it's not just the high schools that are going out and using these fields and these facilities. And so if we can cover them, and our goal with it is to try to get as many AEDs out as we can. So if anybody wants to help support it, they can donate on the AED in 3 page, and that money will go towards, all of the money raised on that page will go towards purchasing AEDs. If you want to earmark it for a specific school, write down, in the comments where you want that money to go, and we'll be happy to get it there. But I think it's been a good initiative. It's been well received. It's a little difficult right now because school has started. Football, soccer, all of these sports are starting to go, and so the athletic trainers are having a little bit of a time finding the time to do it. But the ones that have been very thankful, because a lot of them have been pushing for additional AEDs, and they just haven't had a way to say, hey, look, this is why we need it. And so it's been pretty successful so far. We're really happy with it. We're going to start putting some stuff up on Facebook now that we're getting some of those videos back, and it's been good.
That's awesome.
I like it. That's awesome.
And how many? I know that you said there was basically an application for we need. Have any been given out to date, or is that still in process of collecting the?
It's in process of collecting the data we have. We know we've got about 15 AEDs ordered, and we are in the process of getting those released.
Nice.
So we have everything ready to go. We're just crossing some T's and dotting some I's on the back end before we can get those out. But we want to get them out as soon as possible. And so as the money comes in, we will order more AEDs, because we already have more AEDs requested than what we can get. And if not, we can help them kind of get some grants and things like that to get those AEDs where they need to be.
Awesome. And then we do have a couple of questions that have trickled in there, but before we get to those, just for the sports fans that are out there, and we're getting into where we're in Brown season, football season. Just tell us a little bit about what goes into the planning for something like an NFL game, right? I mean, it clearly has to start long before game one, right? What's that look like? Broad brushstroke, just give everybody an idea what it looks like in the big leagues, not just at your local level.
It's pretty similar to what we're doing locally, right? It starts with your emergency action plan, your standard operating procedures, making sure everybody has a role and they know what their role is. It starts with practicing those emergency action plans. We do one at the stadium, we do one at the facility, and that's just on the sports medicine side. Then you have the whole event staff that is worried about covering the rest of the stadium, which we're worried about, basically 200 people maybe on the sidelines and on the field between the refs, the teams, and the staffs, where the people that are worried about the event have to deal with
30,000.
60,000 people. It depends on how good the Browns are. It depends on how many people are in the stadium. But that's very different. They plan for a full capacity every time.
Of course.
So then, starting with practice, everybody knows we have the cold zone set up with the tub and in the shade with fans, rectal thermometer, IVs set up, obviously for guys, for different things, and making sure that we have our whole area set. We have the same thing for game days whenever the wet bulb globe temperature is going to be above a certain degree. And so without getting too much into the weeds there, it is very similar to what we need to do, just on a much larger scale. Before the games, we have our 60-minute meeting, which is before the home team tells the visiting team, the officials, and then also with the EMS staff there, where X-ray is, where the cold tub's going to be, where what hospital is going to be used for neurotrauma, what hospital is going to be used for regular trauma, if they're different.
Sure.
And then just basically what the protocol is going to be as far as hand signals and things like that to make sure everybody is aware. And we're doing these things. We're trying to bring what we learned in the pros down to the high school level. So I've been working with the Chagrin Valley Conference and Dr. Don Lewis, and we are now doing a pregame emergency action plan meeting for every Chagrin Valley conference event, not just football, but all of the sports. They have a script that they follow talking about those things that I just mentioned, and it'll be the home athletic trainer introducing themselves to everyone. If the athletic trainer isn't there, let's just say for tennis or for another sport where the athletic trainer may not be there, they will have a home designated coach that will go through that and just say, this is the address. This is what we call if we have an emergency. It's not always going to be 911. There are some schools where the firehouse is right across the street, and if you call 911, it gets routed through the city and then may get routed back to them or somebody else. Here's the number for the firehouse directly. We call this if there's an emergency. Talk about where the AED is, where the spine board is, and where the ambulance will be, where the meeting point is to make sure. So we're doing that through the Chagrin Valley Conference, and we're doing that for all of the sports.
That's
so we're
awesome.
trying to take what we've learned with the pros and bring it down, because it's this. None of this is rocket science.
Right.
None of this is difficult. None of this requires any special training. None of it requires any special equipment. It's just time and the knowledge of what needs to be done.
Fantastic. I want to hit a couple of these questions here?
Yeah.
All right. So, actually, John, can you?
Do you want to do? Let's do this one.
I can see a third of it.
No, well, down there.
Oh, thank you. Is there any conditions we should look out for or anticipate giving specific medications if we cool a patient too rapidly? So I imagine this is a concern, right? Is what if I do it too rapidly and then...
You really can't.
Yeah.
And so what we know about cooling, it's not too rapidly, it's too long. So I think the better question there is probably what happens if we cool someone for too long.
For too long.
That's, again, why we want to make sure that we have that rectal thermometer and that core temperature so that you're not overshooting. So you certainly can overshoot if you leave them in there too long, and that's why that 20 minutes, that 20-minute marker is on the protocol. What we know is on average, you will cool somebody by 0.5 degree a minute. And so if you go beyond 20 minutes, you're cooling someone by more than 10 degrees.
10 degrees, right.
Right. And so 10 degrees should
You're
get
saying
you
0.5 degree Fahrenheit.
per minute. And it's about a little bit less than 0.3 degrees Celsius per minute is what we're going for, which the cold IVs won't get to, which ice packs in the groin axilla won't get you to, but getting them in a cold tub will. So if you go too far, you got to get them out. You got to warm them up. You want to make sure you're not causing any hypothermia.
Right.
So that's really it. There's no medication that you can't give whenever they're in the cold tub. If they vomit, if they have loss of control of their bowels or bladder, you keep cooling them. And there was even a case that Core Stringer Institute looked at where they pulled a guy out that was having a heart attack.
An MI, right.
Did chest compressions, shocked him, gave him medications, got him back, and then put him back in the tub. So there's no medication that you can't give. If they're combative, you can give them medication to calm them down. You're not going to have an issue there. So there's really not anything. You won't cool them too rapidly. You may cool them too long,
right.
And then it's just, you pull them out and you warm them up.
I think going even a little further into that question, if the protocol, the 20 minutes of the protocol is truly followed, that's kind of your set of bookends. That's your safety factor in there, right? So if they come out, even if they weren't, say 105, even if we cool them to 95, that's still the range where any of our traditional meds would work, right? So we're not. Yes, we're cooling. He's backing in. There's nothing we can do about that. But in theory, our safety net is that protocol, and we shouldn't get in a place where we get into any real trouble.
And that's when you start thinking about other things. You start thinking about hyponatremia or other reasons why hypoglycemia, and you can do a finger stick if they're in the tube. You can draw blood if they're in the tub. So really, you shouldn't be able to cool them.
You can give them fluids.
Absolutely.
They need fluid resuscitation.
Absolutely.
Yeah, we talked about even monitoring, putting pulse ox on an ear or something, so it's not it's not submerged, and the king of all assessment tools, of course, is capnography, right? I mean, you can watch that.
Yeah.
Their head better be above water, or we got bigger problems than the hyperthermia, right? But all right, what's
I think it's
what's the next one there? Let's see, or should we look for EMS wise, or what would
what should we look for EMS wise?
Yeah.
If we get to a facility after heat injury has occurred, and now the patient's in other extreme core temperatures like 92.
Where you really shouldn't get there.
I think we
that's a good question, and I think we covered it. But you really shouldn't get there if you follow the protocol.
Likewise.
Well, I know what I'll say, Josh, since I was egging you online to ask a question. The emergency departments are actually much better equipped at dealing with cold emergencies.
It's far easier to warm somebody up.
Yes.
Yeah.
We have specific machines designed just for that. I could maybe argue that a Arctic Sun I could use to regulate temperature, but still not as good as emerging somebody for heat emergencies. And to this point, like, I'm a new doc. I graduated from residency 3 years ago, and when I was even in training between 3 and 6 years ago, what were we going to do? And I worked in Akron, and we had marathon runners that came in. We got them wet and blew a fan on them.
Yeah.
And this was 6 years ago. So this has been a big change, and the right change
for everybody.
For everybody.
Yeah,
yep.
right.
And to be honest, I think EMS, because we see it and that's where we're at, or the athletic trainers, they've already pushed the change in the field.
Yeah.
The hospital's the one trying to catch up now because where am I going to put this tub? So right now we don't use tarps. We literally put a body bag on the cot, put the patient in the body bag, put water and ice in them, and zip them up and cocoon them. Yeah. You can do that with a tarp in the field, but
and we are looking at other things too. There's the cooling collar, and so that may be what we do. What we don't know with the cooling collar yet is we know it will cool people at a fairly similar rate to being immersed in water, but will it work on extremely high temperatures? And that's what we've got to do at this point. Is
happen to have one here.
There you go. The cooling collars are great, and it makes sense as to why they would work. But we got to test it against, it works well in somebody that has, a slight temperature, temperature 101, 102 after a cardiac arrest or something like that. But is it going to work on somebody that is at 108? And I was talking to some of the guys in the military, and I won't say where, but they see core temperatures of up over 110.
Oh, man.
So, and they say their guys are fine. They dunk them, and they're fine. They haven't had any.
That's crazy.
Yep.
Well, it's even harder to do randomized controlled trial on those people because it's not super common. I'm not going to push anyone to get to that point. And then I'm going to randomize you to say, I know this works, but we're going to try something else.
Right.
Right. Yeah. No, that's exactly right. So that's what we're trying to. We got something that may be in the works.
Nice.
So we'll see. Stay tuned.
You said something a little bit earlier about wet bulb temperatures. Mm-hmm. What utility do you find, and is it something that if a department had the money, wanted to spend the money, were doing EMS standbys, maybe buying a Kestrel or something like that to no heat index and stuff like that?
Yeah.
How utilitarian is that in your opinion?
So, just the difference between heat index and wet bulb globe temperature is heat index. One is measured in the shade, right? When play most sports on a field, what's the definition of field lack of shade, right? right. So most fields don't have any shade, and so who cares what the heat index is? We're not playing. In the Miami Dolphins have done a great job utilizing the shade in their stadium. So whenever they play at 1:00 on a Sunday, the visitor's sideline is in the sun, and their sideline is in the shade, and it's about a 15 to 20 degree difference in South Florida. So when we played there last year, it was 90 degrees on their sideline. It was 116 to 120 on ours. So for the majority of the first half of the game, so it's very well utilized in some parts of the country. But the wet bulb globe temperature, and really it gets to the sweat mechanism again without getting too far into the weeds. But the sweating is how our bodies do the best job of exchanging heat. And so once you get past a humidity of about 70%, the sweat mechanism is not as effective. And so that wet bulb globe temperature takes into account not just the ambient temperature, solar radiation, the wind, but also the humidity, and the humidity is not involved as much in the heat index. And so by knowing that wet bulb globe temperature, and if you look at the graphs, the heat index at 70% humidity and the wet bulb globe temperature at 70% humidity, there's a difference of about 3 or 4 degrees between what the danger zone is. Right. So the danger zone comes much quicker with the wet bulb globe temperature because of that humidity factor.
And sweating.
So to answer that's a really long answer to your short question of should they get a wet bulb globe temperature? And yes, we do a pretty good job of there are a lot of apps that'll give you the heat index. The wet bulb globe temperature isn't quite as ubiquitous as heat index, and so there are starting to be some apps that are out there that are better, but to have one on site so you know exactly what it is where you are is important.
No, that was perfect. Thank you.
So I want to go to this next question.
What to say?
Which is exactly what we want to have happen with this live show. We want to have a conversation with you guys in the audience.
Yeah, of course.
So thank you, Josh, for clarifying. Josh asks, the instance he was talking about, this was an athletic trainer who overcooled the patient before EMS got to scene. Any issues with reheating them?
And his original question was about the 92 core temp.
Yep.
Right.
Yeah, no. So no issues with reheating them, because this is, when they get overheated, there's nothing structurally wrong with them, right? There's no issue that because they just got overheated and the body's mechanism to dissipate heat stopped working. So assuming they haven't been in that condition for hours and there's no end organ damage and you're within that half-hour time frame and they've been cooled too far, then there's no issue with reheating them. So yeah, and I guess that goes with the athletic trainers as well. They've got to know that 20 minutes is kind of your time to be in the tub. And again, it's that's how important that core temperature is. Yeah. And so that we saw with that case at the marathon, the oral thermometer wasn't accurate, and by 10 degrees usually it's a degree or two. Sure. But it kind of goes to how are you going to get the patient to the ER, and how long is the drive in the ambulance? Like marathon, we're pretty close, we're going to get them there pretty quick, but you're not rolling around with a tub of ice in the ambulance either. Regardless of how cold you can get everything, they're still going to probably have their temperature rise as they go. So there's no issue with reheating them.
And honestly, 93 degrees is probably the old target temperature for our old cardiac arrest standard. So you'd come in a cardiac arrest, if you went in early normal, we'd cool you down to about 93 degrees.
Right.
And the same thing happens with cold or hot. One of the big risk factors is going to be cardiac dysrhythmias. Mm-hmm. 93 is not cold enough that I'm really going to worry too much about a cardiac dysrhythmia. Yeah. 108, I'm going to be sphincter tightening, all hands on deck. We got to cool this patient.
And we were targeting that to protect their brain.
Yeah, we really were.
Yeah, yes. That was the
therapeutic hypothermia.
Hypothermia, right?
Yeah. Well, the other thing too, I think when someone goes in the tub, maybe to expand on Josh's question to an extent, for the athletic trainer and for EMS, when the patient goes into the tub, there's a lot going on. Maybe we are performing other treatments because you put them in an ice bath does not mean treatment stops. And I really like that you guys expanded on that. And the other simple thing to do is everybody has a cell phone. Set a timer for 20 minutes on your phone and put it back in your pocket, is another safety net, because there's so many more apps out there that are just a good reminder, because it's hard in that setting to really keep track of time. Like, how long have we been doing this? You know, it's like on a cardiac arrest. Is it time for another epi? I think it's been 3 to 5 minutes, right? You know, we've really overcome that in our teaching. So, you know, there's apps to run a code where it literally can set an alarm on your phone. It's gonna it alarms every 3 minutes. And in my head, all right, I got to give an epi, and we've done that with my team. And as you guys are all talking, I'm thinking about that, and Josh's question kind of brought that to light. So as soon as they go in, hey, what time did you start? You know, if I thought it was about 5 minutes ago, then I'm gonna set my timer to 15 minutes. Or, you know, can we get that core temperature? But if I was the one that was there when they went into the tub, use the cell phone that's in your pocket. Everybody has one.
Yeah.
It's a simple
And
thing to
12
just
minutes into a 20-minute timer.
yeah, and you're gonna know instant feedback too. Just, I mean, I don't know, Doc, what you think about that, but
I think
just
it's
throwing it
great.
out there. Just
Yeah.
set a timer, set it down, and that's gonna call a ball if we're outside of that.
But people are reticent to take extra time to do something like that, even though it pays dividends. You know, that you're not going to overshoot. You know at a half degree, you know, a minute, you know where they're at, right? And they start waking up. You say, okay, that should have come down 6 degrees or 8 degrees or whatever.
Gives you good benchmarks
it's
too.
the-
How
it's the
are we
same-
progressing with our
Yeah,
treatment?
it's the same thing about hitting the the NIBP button on you're not that good. You're not going to remember to keep pushing it, right? Just let the machine do the work, right?
Yeah.
We're surrounded by tech these days. Utilize it. Yeah.
Yeah.
And I think the other thing is you're dealing a lot of times, especially in the pre-hospital setting, you're dealing with athletic trainers that don't run codes. They've probably never been, or very rarely have been in situations like this. And when you do run a code, the time either goes super fast or super slow. And most of the time, if you ask somebody how long they've been running this code, they're either slow or fast, unless they're running codes
Constantly,
pretty
right, yeah.
regularly. And so to utilize that and just say, hey, you know, whatever device you use, set a 20-minute, you don't even have to type it in. You can just say, hey, set a 20-minute timer, and it'll do it. And then you have that feedback there quickly, so you don't. I practice ended at 6. It happened, 20 minutes before practice ended. They have no idea what time it is.
Not
So
a
just
clue.
use the technology.
It's hard for us who are experienced people to respond to an emergency. And I get that same, like either 3 minutes went by really quickly, or I'm asking for what time we gave an epi and it was 30 seconds ago.
Yeah, it depends on the tasks you're kind of doing at
Correct.
hand.
Yeah.
You know,
Yeah.
if you just put the patient in the tub and I'm like, all right, I want to start an IV. We already got our core temperature. Maybe I want to put them on the monitor, get my pulse ox. I start doing stuff. I'm like, I've done all these things now. 5 minutes. In my brain, it's gonna, like, a timer's gonna go off. Well, I've went through 5 minutes of treatment at least, so then I want to go back at that, right? And then when you're not doing treatment, you're just like, okay,
Yeah.
we're just all staring at each other,
hand,
kind of
right.
like
Yeah.
holding the person up in the tub, and it's like, is it working? We know it's working, but how long have we done it for? So it's just one
Yeah,
of those
and,
things.
and
That's
you
fine.
were sitting there for like all of 15 seconds. You're like,
Yeah,
all right, we got to do
we
something.
always want to,
Yeah.
that's
We're
fire,
due, yeah.
that's fire and EMS, and I'm sure it's
we're
the same
do,
thing with
right?
athletic trainers. We're doers. We want to fix it. We want to do it now.
Yeah.
So when you're like, okay, I got nothing to do,
Yeah.
It seems wrong.
It does.
It really does.
It's awkward.
It
You're
seems
just
wrong.
like,
Time slows down for me when I'm farther and further into a code situation. That we've done all the things. We're just
Yep.
now. It's the cookie cutter stuff. We've tried all our
Yeah.
drugs. We're at one drug cycle now. We're going through our paces, and
Yeah.
so Josh excellently sent
Yes.
in another
good
comment.
questions.
Yeah. So patient that he was talking about was confused, slow to respond, had muscle tremors after being a heat injury patient. So it sounded like they cooled him, and then he started to shiver. Yeah.
Yeah.
So dry them off. Dry
Dry them off,
Yep.
warm them up.
Warm
Warm them up. Cover them up with blankets.
Send him to the ER. We'll do some blood tests, start some fluids on him, and hopefully we'll go home.
Yeah, and just don't rough handle the patient.
Correct,
Throw that
yeah.
in there. We don't want to jostle them.
Yep.
All right. Well, I think that's about wrapping up the live. I was hoping to get a few more people to hop in here, but we changed the day on you, so we'll give you we'll let you slide this time. But thank you all so much, Dr. Flannery. Thank you for coming back, and even folks, even if you have questions beyond this, prehospitalparadigm.com. We have Ask a Podcast question. We can either get a response from Dr. Flannery, or we certainly later in the year we've got some questions that have been asked. We've got a whole catch-up, a whole bucket of question and answer stuff that we've done. I believe that's a December. I think it's our December, December episode, and then pre-hospital
Fifth Monday thing. Sorry.
Yeah.
Is it a fifth Monday or is it December? Anyway,
I can't remember.
There's a whole question and answer thing. Those are your questions that we spend the time, we dissect and we go through stuff that is real cases from the field that you want some insight on or some feedback on. We've got that up and coming a little bit later in the year. We've got prehospitalparadigm.com. Most recently, under podcast, we added a calendar of events. So there is, I'm not looking at it right this second, but that episode's in there. And if you throw anything in that needs answered, we'll either get Dr. Flannery back or we'll answer it. We'll get the answer from him and answer it in one of those additional question and answer episodes. And also, the Prehospital Paradigm podcast.com is all of our free open access medical education that UH puts out. So that's all of our medical director Mondays. That's all of our pharmacy Fridays. It's really becoming the catch-all for a lot of things. So check out the prehospitalparadigm.com. All kinds of good information there. We're building out new stuff. It's seemingly every month, so we've got a new initiative that we're putting up there, and then like us on Facebook, follow us on YouTube, and thanks so much, and we'll see you guys again back here in a month. So.
Thank you for having me. I appreciate it. If anybody has any questions about the AED-3, just Google #AED-3 and they can check it out. So thank you for having me. This has been great. Really a lot of fun.
Thanks for coming out. I appreciate it.
Thank you very much.